Hello, my name is Tiana Gross. I'm a P3 student from San Antonio, Texas, and I'm here to present my journal club. So to begin with the title of my article is Antibiotic Treatment Strategies for Community-Acquired Pneumonia in Adults. I then did a citation on my article. It came from the New England Journal of Medicine. Some of the authors in my presentation were Cornelius H. Van Werkhoven and Leontine Van Elden Jr. So the study was made possible by a grant from the Netherlands Organization for Health Research and Development. So some background on community-acquired pneumonia is that it is the leading cause of hospitalized deaths in the world. The recommended antibiotic treatment can be based on a severity of the disease or a prognostic risk score, such as the CURB 65 criteria. And within this diagnostic criteria, the patient must have cough, sputum production. It may even be rust colored. Temperatures between 36.1 degrees Celsius or lower and 38 degrees Celsius or above. Auscultations such as like decreased breath sounds, leukocytosis, which is an increase in white blood cells or an increase in bands greater than 15%. The patient may have difficulty breathing, fast breathing, so the respiratory rate should be greater than 30. Along with the blood urea nitrogen level should be 20 or greater. And the patient should also experience confusion and disorientation. So according to the guidelines, the recommended treatment for a non-ICU patient with CAP is the combination of a beta-lactam plus a macrolide, or a monotherapy of a respiratory fluoroquinolone, such as moxifloxacin or levofloxacin, for empiric therapy. The goal of this study is to compare the different empiric therapies in non-ICU patients that have community-acquired pneumonia by the following medications. So I'll repeat them again. The beta-lactam monotherapy, that's what we're comparing the other regimens to. The beta-lactam macrolide combination therapy and the fluoroquinolone monotherapy. So this study was in regards to a 3-month all-cause mortality rate in adults who were suspected to have CAP. The trial design was a practical cluster randomized crossover trial. This study took place at 7 hospitals in the Netherlands from February 2011 to August 2013, so a little bit over 2 years. The study was approved by the Ethics Review Board at the University Medical Center Utrecht, local institutional review boards, and the Antibiotics Committee at each hospital. So some inclusion criteria that I found was that the individuals had to be 18 years old and above that were non-ICU patients with suspected CAP needing antibiotic treatment and hospitalization. So I found out that 2,283 patients total were included in this study. There are more men than women, so there are about 1,317 men and 966 women. Some exclusion in this study were patients that had cystic fibrosis. The subjects were adults suspected with community-acquired pneumonia. Primary endpoint included all-cause mortality within 90 days from admission into the hospital. Some secondary endpoints were the time to start oral treatment, the length of stay in the hospital, and any complications during the hospital stay. So if they caught an infection while in the hospital. There was no follow-up that was recorded in this study. The duration of this study, like I said, was a little bit over 2 years, so it's about 30 months. The population of this study included non-ICU hospitalized adults suspected with community-acquired pneumonia. And like I said again, there were a lot of patients in this study, specifically 656 patients that were on monotherapy beta lactam. 739 patients were on the combination of the beta lactam and macrolide therapy, and 888 patients were on the fluoroquinolone monotherapy. Some statistical analysis was that the analysis were executed with an intent to treat principle. Absolute risk differences were determined by taking the average of the computed individual risk from each group, and the non-inferior sample, in this case being the beta-lactam monotherapy, was assessed in a one-sided test at a significance level of 0.05 with using a two-sided 90% confidence interval. So the hospital length of stay and the time antibiotics were administered were tested with a mixed Cox proportional hazards model. Sensitivity analysis only included individuals with confirmed CAP and were assessed at a 30-day mortality and was determined by a two-sided 95% confidence interval. So some baseline characteristics with dealing with the results included that blood and sputum cultures, as well as the urinary antigen testing. So they found Streptococcus pneumonia and Legionella pneumophila to be associated with this. Some primary endpoints were that the difference in the adjusted risk of death between the beta-lactam strategy and the beta-lactam macrolide combination strategy was about 1.9% in favor of the beta-lactam strategy and negative 0.6% in favor of the fluoroquinolone strategy. Some secondary endpoints were the average length of stay in the hospital was about 6 days for all treatments, but the average length of stay or the average duration for the IV fluoroquinolones was about 3 days, while the others being 4 days. There were no adverse events listed. I was surprised about that. Um, Now, in conclusion, the strategy of preferred empirical treatment with beta-lactam monotherapy was non-inferior to strategies with beta-lactam macrolide combination therapy or fluoroquinolone monotherapy in terms of a 90-day all-cause mortality. So this trial or this study found out to be that the beta-lactam monotherapy is just as good as the fluoroquinolone monotherapy or the combination therapy between the beta-lactam and a macrolide. So some strengths that I considered in this article was that they had in table 2, it was a breakdown of all the logistics in the study, such as the patients that had comorbidities that would take into effect the different type of treatment that that patient may be on, as well as if vaccinations were given, to even determine if the patient may be susceptible to a certain microorganism such as streptococcus or pneumococcus pneumonia, for instance. Comparison of the different treatment regimens. So that was another strength that I did like. They didn't just look at one particular therapy regimen. They looked at all three. Some weaknesses that I found in the study was that it didn't discuss any of the adverse events. So you wouldn't know exactly if one therapy may be better than the other, or if it may be a risk factor in a patient that does have comorbidities, because some of the events that have taken place or the events that happen, you wouldn't know if it occurred in somebody that may have that or may have a disease state. So another one was that based on the season change, one drug therapy may have been used more or less than the others in regards to the microorganism needed to be uncovered. So in this article, they talked about in 2012 to 2013 during the winter season, they saw a lot of the atypical microorganisms, so mycoplasma, pneumonia, chlamydia pneumonia. They saw a lot of those microorganisms in patients. So the fluoroquinolone monotherapy might have increased a little bit, and you didn't see a lot of the use of the beta lactam therapy. So another one was that there was no follow up, and that it wasn't as accurate because some information that was missing in the trial, it was assumed to be normal. So, such as like heart rate, um, I guess different levels. It wasn't, there was no follow up. So, if there was no follow up, you wouldn't know the levels. So, I guess, in the study, they just assumed that everything was normal when that may not have been the case. So, in conclusion, overall, I thought that this article was done well. The objective did prove that the beta lactam monotherapy was just as good as a fluoroquinolone monotherapy or a combination therapy of the beta lactam and the macrolide. And here I summarized my primary literature, and I thank you for your time. Have a good day.